Hi everyone, I want to talk about Hodgkin lymphoma. Hodgkin lymphoma. You heard about that before? Okay, let's go. Before talking about Hodgkin lymphoma, I want to talk about lymphomas generally. Lymphomas are cancers of either the B or T lymphocytes in the lymphatic system. We have Hodgkin or non-Hodgkin. Could be aggressive or indolent. Aggressive types are also called high-grade, while the indolent types are known as low-grade lymphomas. Examples of the indolent or low-grade lymphomas are Walderstrom macroglobulinemia, small cell lymphocytic lymphoma, and follicular lymphoma. Examples of aggressive lymphomas would be Burkitt lymphoma, Hodgkin lymphoma, T-cell lymphoma, and diffuse large B-cell lymphoma. That's what we call gray zone lymphoma. This is very rare, very common among teenagers and young adults. Hodgkin lymphoma features of large B-cell lymphomas are present here. So it is gray zone. It's like the midpoint, the middle of both spectrum here. It's more aggressive and metastasis is possible. With that, I've crossed from the gray zone to Hodgkin lymphoma. Hodgkin lymphoma affects thousands of people and thousands are diagnosed annually globally. There are two peaks, the young and the elderly. There is a peculiar feature pathologically, and that is Steinberg cells. Steinberg cells are present in Hodgkin lymphoma. They are absent in non-Hodgkin lymphoma. Steinberg cells. That is the diagnostic feature that the pathologist will see and say, yeah, this is Hodgkin lymphoma, Steinberg cells. Greater than 80% of people diagnosed with Hodgkin lymphoma having Steinberg cells pathologically will have 80% being cured. In other words, non-Hodgkin lymphoma is less curable. Hodgkin lymphoma is very curable. 80% of diagnosed patients with Hodgkin lymphoma will have complete cure with chemotherapy or radiation or combined. More on Hodgkin lymphoma. You could see these pretty beautiful colors. Yes. Steinberg cells are present here. I'll compare that and contrast now to non-Hodgkin lymphoma very soon. So comparing to non-Hodgkin, Steinberg cells are present here. They are not present in non-Hodgkins. Upper body's lymph nodes mostly, like chest, neck, and armpits. That is where the lymph nodes will be localized if it is Hodgkin lymphoma. So it's going to be upper parts of the body, the chest region, that is supraclavicular, axillary, infraclavicular, and the neck region, that is cervical, posterior auricular, anterior auricular region. Those are the regions where you're going to find the enlarged lymph nodes in Hodgkin lymphoma. Non-Hodgkin could be found anywhere. Subtypes are treated similarly if it is Hodgkin lymphoma. Subtypes are treated differently if it is non-Hodgkin lymphoma. And remember I said Hodgkin lymphoma will have Steinberg cells, which non-Hodgkin will not have. Median age of diagnosis is 39 years old, in Hodgkin lymphoma. Non-Hodgkin is very common among elderly, 55 and above. Hodgkin lymphoma is less common, while non-Hodgkin is very common when it comes to lymphoma. It is often diagnosed early. Late diagnosis is common with non-Hodgkin. It's a treatable disease in 80% or even more. Non-Hodgkin is less treatable. Okay, another pretty page. You can pause and then reflect on the previous slide. Now, non-Hodgkin lymphoma. Stem cells are absent here. Remember I said they'll be present if it is Hodgkin. And remember I said when it is Hodgkin lymphoma, is limited to the upper chest, chest region, that is the chest, the neck, the armpit. When it comes to non-Hodgkin, you can find it anywhere. The groin, the popliteal, the armpit, the neck, occipital, anywhere you can find non-Hodgkin. Subtypes are treated differently. Subtypes are treated differently here, but subtypes under Hodgkin lymphoma are not treated differently. Diagnosed at 50 or greater than 60 years old, that is in non-Hodgkin, but in Hodgkin is diagnosed at mid-age of 39. Non-Hodgkin is very common. That is unfortunate. A more terrible one is more common. Why? I don't pray for any cancer for anybody, not for myself or anyone, but if everybody will have to choose between non-Hodgkin lymphoma and Hodgkin lymphoma, will have no majority, if not all of us, choosing Hodgkin lymphoma. Unfortunately, the bad one is more common than the good ones. Is that not the way the whole life is? Good people are less compared to bad people, right? I think so. It is diagnosed late. Non-Hodgkin is diagnosed late. Might be one of the reasons why it is very difficult to treat. So the next point is difficult to treat, while Hodgkin is more easily treatable. Okay, the nodes that could be involved would be neck, axillary, supraclavicular. That would be in Hodgkin lymphoma. But you can have mediastinal, abdominal, groin, spleen. All these lymph node regions will be involved in non-Hodgkin lymphoma. But in Hodgkin, it's limited to the upper part of the body. Extranular involvement is very common, like in gastrointestinal tract, it could involve the stomach, the bowel, could affect the bone marrow, the liver, the skin, the head and neck, and bone. What are the possible clinical features? The clinical features are similar, whether Hodgkin or non-Hodgkin. So when I will start presentation on non-Hodgkin, the clinical features here and that of non-Hodgkin could be matched. Okay, so lymph nodes will be enlarged, but painless, rubbery, hard, matted, fixed to the underlying structure sometimes. There may be fatigue with low appetite and B symptoms like weight loss, fever, night sweats, and severe itchiness. How do we make diagnosis here? I have a separate video on full diagnosis of lymphomas. Please check my channel for that. So I will not waste your time here going over the same thing. That would be a kind of repetition. For Hodgkin lymphoma, the treatment will be BAVD. Well, A will start before B, but that's the way we abbreviate it most of the time. BAVD, that is Bleomycin, Adriamycin, Vinblastine, Dacarbazine, given every 2 weeks with radiation or without radiation. Radiation will damage thin lymphocytes. Post-treatment or post-chemotherapy or post-radiotherapy. You can do citron emission tomography with CT. Other treatment is bone marrow transplant. Because, you know, I have just said that it's a treatable disease. So after you've given your treatment and the individual is in complete remission, then you can do this. You can have autologous or allogenic transplant. In the case of allogenic, you have HLA match. That is when you invite many people to have them screen for HLA match. And if you are lucky to have a match, and you become a friend to the individual. The prognosis is good. Now, we don't need a prophet, we don't need a seer to tell us that, because I've just said now a couple of minutes ago that is treatable. So the prognosis is good. But the question is, if greater than 80% will have complete remission, how about the unlucky 10 to close to 20% that may be not cured? Okay, with that, I've come to the end of Hodgkin lymphoma presentation. Thanks for listening. Please check my channel for non-Hodgkin lymphoma that I will present in the next few minutes or hours. Thanks for listening to my presentation. Kindly subscribe to my channel and you'll be able to get my presentations immediately they are published. Thank you.